This is presentation number 7 in neurovascular imaging series. Mind you that neurovascular imaging series number 6 was cancelled and incorporated with advanced MRI number 3. This is prepared by Prof. Sharaf and revised by Prof. Rami Edward. Now on CT, if we have acute hemorrhage, this up to 3 days, of course all will know that it is hypertense, but this is under one statement that hemoglobin is not less than 8, because this will affect the density. In subacute hemorrhage, 3 days to 14 days, there is degradation of protein hemoglobin products evolving from periphery to the center, and more than 2 weeks it is chronic hemorrhage behaving like CSF, hypodense. In MRI, a hyperacute, acute, early subacute, late subacute, and chronic were described. The famous for us is the acute, in which we can get dark T1, dark T2. The early subacute, in which we get bright T1, dark T2, and the late subacute, in which we get bright T1, bright T2. This is number 1. Number 2, that we always get more than one phase. A hyperacute, but at the center it is going to be acute. An acute, but at the acute, but in the center it is going to be subacute, early. An early subacute at the periphery, but in the center we get late subacute, and so on. The second thing is that the margin will show what we call the hemosiderin dark T2 ring, and this is starting early. In hyperacute, which is less than 6 hours, we have predominant oxyhemoglobin, and thus it appears dark on T1 and bright on T2. In the acute, which is 6 to 24 hours, the oxyhemoglobin predominates, dark on T1 and darker on T2. In early subacute, which is 3 days to 4 days, methemoglobin begins to predominate, first being intracellular, appearing as bright T1, dark T2. Then the late subacute, which occur more days after, it will be bright in both. Chronic hemorrhages usually follow the CSF, beside the hemosiderin granules appearing as marked hypointense rim because of the macrophages. On CT, as we have just mentioned, an acute is hyperdense, a subacute may be hypodense, and after 3 weeks, 2 to 3 weeks, hemorrhage simulates CSF. So what is this? Now here we get T1 on the left, T2 on the right, and in T1 it is dark, in T2 it is bright, but still we have the center. Now think about the center, because the central part on T2 with the images starts to blacken. That means it is going to acute. So hyperacute, less than 6 hours, we have predominant oxyhemoglobin. Generally it is dark on T1, bright on T2. except for the central part, which may change to the second phase. Here we have the second phase, the acute form, acute hemorrhage, and we have dark T1, dark T2, but still on the margin you might have some changes seen in T1. Here it is, acute to early, bright in T1 and dark in T2. So in early subacute, which is a change at the center, the central part is always older than the peripheral part. The central part here is showing bright T1 and dark T2. Here we have the late subacute, in which we get bright on T1 weighted images, bright intensity on T1 weighted images. Here we get late subacute going to chronic, and we said that the chronic part is the central part. The central part is the older part. The periphery here is showing hemosiderin rim, and as we said, late subacute means bright in both T1 and T2, and this is the margin of the region. Bright in T1, bright in T2 with a hemosiderin rim. So bright in both is late subacute. What are the causes of intracranial hemorrhage? Mainly it is hypertension. This is the most common, but of course you should include tumors, trauma, arteriovenous malformation, aneurysm, coagulopathies, amyloid angiopathies, hemorrhagic infarctions, especially venous infarction of superior sagittal sinus thrombosis, and vasculitis. Now, some words about hypertensive hemorrhage, which is the most common. 80% of hemorrhages in the basal ganglia, 10% in the bones, 5% in the deep gray matter of the cortex, and 5% in the cerebellum. Usually it is simple. Usually there is complete ring. Marginal enhancement is rare. Benign evolution is usual, and it is usually solitary. So the most important thing here is that the hemosiderin ring is usually complete, and it is simple, and is going in the evolution we have just mentioned, from hyperacute to chronic, and usually it is a solitary lesion. Now this is a patient with small infarct at the region of the caudate, and here it is seen as restricted in diffusion, and here is a hemorrhagic infarct seen as restriction with the dark T2, and as dark T2 it is an acute hemorrhage. Dark T2 is an acute hemorrhage. Okay. Or early subacute. Acute hemorrhage or early subacute with the region of the infarct. So it is a hemorrhagic infarct, and this is a small infarct at the region of the caudate seen as restriction. So acute and early subacute shows dark T2, as we said. Now hypertension, which is the commonest non-traumatic cause, and we mentioned the sides, and we give the high intensity reason due to methemoglobin, and this is CT showing hypertension at the region of the basal ganglia, which forms about 80% of cases. Hypertension, hemorrhage, hypertensive hemorrhage in the region of the basal ganglia, 80% of cases, and it is usually homogeneous, simple, and follow the evolution we mentioned. And usually it is centered in a region of an infarct. Hemorrhagic tumor, here we have a heterogeneous incomplete ring with massive vasogenic edema surrounding, and this is not a common site for hypertensive, as we said, and we have a soft tissue nodule inside, intermediate intensity, hemorrhagic tumor. This is the bilateral frontal hemorrhages, petechial type of hemorrhages, which can occur in trauma. We have normally enhancing intracranial structures, and we have location for cortical contusions are the anterior and inferior portions of the temporal, frontal, and occipital lobe. So this is a traumatic type of intracerebral hemorrhage. Interventricular hemorrhage is usually follows hypertensive hemorrhage, which rupture into ventricle, but tumors can do, and vascular malformations can do the same. So interventricular hemorrhage is either hypertensive, tumor, or AVM. Interventricular hemorrhage filling as sediment in both occipital horns, and on the right side there is another case with bleeding into the frontal sinuses and third ventricle, with dilatation, of course, of the corresponding lateral ventricles, as seen by the temporal horns, dilated temporal horns. In the last two images, we have sediment of blood within the ventricles, as seen by MRI. Now come to the subarachnoid hemorrhage. Subarachnoid hemorrhage is filling of the CSF space, sulci, cisterns, and this is the appearance of massive subarachnoid hemorrhage. Can be caused by aneurysms. These are 90% of cases, but trauma, AVM, coagulopathy, or idiopathic can do. Cerebral aneurysms are saccular in 80%. This could be developmental, degenerative, trauma, infection, means mycotic, neoplastic, oncotic, flow-related aneurysms, and vasculopathies like systemic lupus, Takayasu, fibromuscular dysplasia, fusiform aneurysm, and dissecting aneurysm. So saccular aneurysms, you have, this is the most common. As we said, it secular in 90% of cases, or 80% of cases. Sacral aneurysms are true aneurysms, and as we said, developmental, degenerative, vasculopathy, trauma, infection, tumor. It occurred in 2% of population as developmental. They are multiple in 20%, giant in 25%, reaching up to 25 millimeter, and increased incidence in adult polycystic kidney, aortic coarctation, the presence of fibromuscular dysplasia, collagen disorders like Marfan's and Ehlers-Danlos, with possible spontaneous dissection. This is a bilobed aneurysm confirmed on the cerebral angiogram. Bilobed aneurysm. This is acute subarachnoid hemorrhage, ruptured anterior communicating artery aneurysm. If the pupil dilated, these points are posterior communicating. Rupture anterior communicating artery hemorrhage should be suggested in bilateral subarachnoid hemorrhage in the interhemispheric fissure. So if you find interhemispheric and bilateral, suggest an anterior communicating artery rupture aneurysm. Subarachnoid hemorrhage and interventricular hemorrhage at the same time clinically it gives severe headache. Angiography is a modality of choice to check for aneurysms. Mycotic aneurysms means infection of the vessel due to usually bacterial, and they are multiple, haphazardly distributed, usually as a complication from the infection coming from the heart. Mycotic aneurysms. Complications of subarachnoid hemorrhage are hemorrhage-induced hydrocephalus, vasospasm leading to secondary infarction, leptomeningeal. So that's why you have association between infarction and hemorrhage. Leptomeningeal superficial siderosis, iron deposition in meninges secondary to chronic recurrent subarachnoid hemorrhage. This results in iron-loaded meninges, which are seen in the MRI. Thank you.